Very good morning to one and all. Sir, shall I present the case?
Yeah, please start.
Okay, sir. And my patient, Miss Reshma, 25 years female. She is a resident of Sikar. She is a married woman. She admitted in Durlabji Hospital on 19th January 2023. Chief complaints. Patient came for further management. She underwent a lab cholecystectomy on 4th January 2023 elsewhere with draining a bile. History of presenting illness. She was apparently normal a month ago. Then she had a recurrent upper abdominal pain and dyspepsia, not associated with any fever, jaundice, uh, for which she was evaluated and she found have symptomatic cholelithiasis. She underwent a laparoscopic cholecystectomy on 4th January 2023 in Sikar. Surgery details. The surgery duration was approximately 90 minutes. During surgery, they were transfused 3 units of blood intraoperatively. The drain was placed in the right upper abdomen. Postoperatively, she was managed in the ward and they transfused 2 units of blood. This detail is given by the patient attender and patient attender. And she was resumed oral on first postoperative day. In first postoperative day, drain was draining around 250 ml of bilihemorrhagic fluid. And second and third postoperative day, the drain amount is about 150 and 100 ml serosanguinous. And she was doing well. And she was discharged on third postoperative day with drain. Following subsequent days, drain is not draining anything. And peridrain, there is a minimal soakage. Serious soakage was present. She visited to the hospital and drain was taken out. On 13th January, 9 postoperative day, she had a severe pain abdomen with distension, associated with breathing difficulty, for which she was admitted in the hospital and they performed the sonography abdomen, which was suggestive of intra-abdominal collection. They aspirated around 110 ml of bilious fluid from the left upper abdomen. They placed a one drain in the lower abdomen. And she was symptomatically better. She was started on antibiotics. On 17th January, then 13th postoperative day, she again had a abdominal discomfort. For that, she underwent a sonography abdomen, which is suggestive of intra-abdominal collection. For that, they placed her 2 drains, percutaneous drain in the right and left upper abdomen. On 18th postoperative day, PCD from the lower abdomen was draining nothing. After a sonography screening, they took out the lower abdomen drain. Then she referred here to Durlabji Hospital for further management. Presently, the patient is doing well, tolerating a oral diet, tolerating oral semi-solid diet. PCD is draining approximately 600 ml of bilious fluid, bilious per day. And there is no history of fever, no history of yellowish discoloration of the urine or sclera, no history of clear cholesterol, no history of pruritus, no history of bleeding manifestation, no history of any postal hypertension. And past illness, she doesn't have any comorbidity. There is no past surgical history. Family history is not contributory. She is a vegetarian diet, normal blood and bowel habits. There is no history of drug allergy or drug addiction or drug abuse. Summary, 25 years old female. She was diagnosed having a symptomatic gastro disease for which she underwent a lab cholecystectomy. Intraoperatively, that event was they transfused 3 units blood, and postoperatively from the drain, it was draining a bilihemorrhagic fluid, which was subsequently draining nothing. And eventually on 9th postoperative day, she developed a intra-abdominal collection for which they drained and they put a one percutaneous drain. And subsequently, she again developing an abdominal discomfort for which the sonography is suggestive of intra-abdominal collection. They put 2 drains in the right and left upper quadrant. Presently, she came here for further management. My provisional my provisional diagnosis is status lab cholecystectomy, bile duct injury with controlled biliary fistula, controlled external biliary fistula. Uh,
So just I want to ask something. The patient underwent lab chole on the 4th of Jan this year, right?
yes, sir.
And she was admitted on 19th Jan at your center.
Sir, your voice is not clear, sir.
I'm saying the patient underwent cholecystectomy on 4th of Jan,
Yes,
4th
sir.
January, and then
Yes.
she was admitted on 19th January.
Sir, actually, she was operated lab cholecystectomy on 4th January. She was
Mhm.
discharged on third post-operative day, 7th January. She was again readmitted on 13th January in that sicker hospital, sir.
No, it's
Then
okay. But when did she present to your center?
19th January, sir.
19th January means post-op day 15,
Yes, sir.
right? But I
Yes,
think in the history you mentioned that on post-op day 18, PCD was removed.
sir. On, sorry, sir.
On 18th post-op day, PCD was removed from the lower abdomen.
No, no, sir, no, sir. On 17th January only they removed, sir.
Okay,
Sorry.
so just be careful during the presentation of history because if you mention things in chronological order or post-op day wise, right? So you have to be very careful that such kind of mistake doesn't happen in the exam,
Okay, sir.
right? So this is just one point, you know? So you have to be very careful. And second,
Yes,
just
sir.
uh, going through the entire, uh, I would say the uh, picture of the presentation from lab chole till the presentation to your center. So, what is the thought process going in your mind? What has actually has happened? Because you have given one diagnosis, not actually the differential diagnosis, and categorically you have mentioned it is a post cholecystectomy bile duct injury with controlled external biliary fistula. So, is it so? Can you think of some other condition in which the presentation can be like this?
Sir, it might be a injury to the accessory tub that could have presented in the late.
Hey, but
And
still, it will be a bile duct injury, right?
yes, sir.
See, once you have mentioned a bile duct injury, it means it encompasses all kind of bile duct injury, whether it is to axillary duct or main duct, all types, right? But I'm just trying to ask you, what is the thought process going in your mind with this kind of presentation? Is it always bile duct injury?
Sir,
There may be some associated other problem, or there may be something else, not necessarily a bile duct injury,
sir, from the history, I can
hmm,
make out few things, sir.
right?
The duration of surgery was 90 minutes. They transfused streams of blood. So it may
Yes,
be inappropriately biliovascular injury, one possibility.
right.
And in the meantime, patient was all right at the time of discharge, and they took out the drain till the time she was fine. After the drain took out on 9th post-operative day, she's having a choriobiliary ascites. For that, they drained and they put a PCD.
Mm-hmm.
Sir, I'm thinking, I'm thinking in terms of post-cholecystectomy, bile duct injury only, sir. Because if associated to any bowel injury, it may present with peritonitis, sir.
Right. So I think when you mention the in the history, right, the patient was doing fine, but categorically, I think it will be better to uh, tell that patient was not having any nausea, vomiting, patient was accepting orally, patient was passing fat as a stool,
Okay, sir.
right. So indirectly, otherwise GI function was normal because you have not mentioned these things categorically, right. So go back to your
Yes, sir.
slide, previous slide presentation, right. So you have mentioned next slide. You have just mentioned he was doing fine. But what do you mean by doing fine? है ना? She was doing
Yes,
well.
sir.
So you have to be categorically mention that there are no other problems. So this will
Okay, sir.
indirectly indicate that patient was not having any kind of pancreatitis. It was just collection, non-infective kind of, right? At the same time, if I ask why there is not associated vascular injury, because
Uh,
patient had 3 units of blood transfusion, there was biliohemorrhagic drainage in the immediate post-op period.
uh, Sir, actually, the 3 units blood transfusion intraoperatively, which is highly suspicious of associated vascular injury also, sir. It might be a uncontrolled bleed from the cystic artery, or it might be a injury to the right
It may be
hepatic.
any vascular, it may be any
It could
vascular
be,
injury, right?
yes, sir.
Okay, so it is not any kind of enteric injury, duodenal injury. It is basically a kind of uh, biliary tract injury, maybe
Yes, sir.
associated with the vascular injury. We don't know
Yes,
yet.
sir. It might be associated with vascular injury also. We are not sure, sir, at present.
Okay, right.
So, I mean, that's very strong suspicion of vascular injury. Why in a lab cooling, one would need 3 units of blood? Yes, Gopi. Gopi. Gopi.
Sir?
I'm Dr. Chaube. You see, this patient, I'm sure he must have had vascular injury. Otherwise, in a lab coli, why anybody would give 3 units of blood intraoperatively?
Uh, Sir, the that might be a. I am
What?
suspect in terms of there might be also any biliovascular injury, sir.
Yeah, I'm sure because I mean that's a very obvious thing because 3 units of blood is a substantial amount of blood being given intraoperatively.
So there are only possibilities that might be also with any biliovascular injury that
Yeah.
signifies the 3 units of blood transfusion intraoperatively and 2 units postoperatively, sir. I just also want to know the preoperative basic blood parameters and liver function, preoperative blood ionization and sonography abdomen, sir, prior to the surgery.
Vishal sir, we can continue.
Yeah. So in this context, what else would you emphasize on the past history? That patient has
Past history,
underwent,
actually, I just want to know about is there is any history of pancreatitis, sir?
right? Anything else?
Past history of any jaundice, and is there is any hematological disorder she's having, sir? I just want to know.
No. Basically, he underwent cholecystectomy. There is a suspicion of it was a kind of difficult cholecystectomy requiring blood transfusion. Then she had bile duct injury, right? So you would like to
Yes, sir.
know all the factors which led to such kind of difficult cholecystectomy. So when was the last episode of biliary colic or pain abdomen? Was it cholecystitis? Did it require any kind of admission? Right? Did the surgeon
Yes,
operate
sir.
too early after cholecystitis or at the time of cholecystitis? So indirectly, you can just make out based on the history because at this stage you have not gone through the previous record. So right,
Yes,
you
sir.
have
Yes,
rightly
sir.
said the
Actually,
pregnancy of pancreatitis.
yes, sir. Actually, she's having a pain in the right upper abdomen for past 1 month, for which she evaluated, she found to have only gallstone disease, sir. Apart from she, nothing, sir. No
Yeah,
pancreatitis.
so right, but she has been having pain for the past 1 month. So was it a
Yes, sir.
continuous kind of pain or it was an intermittent pain? It was biliary colic or there is a suspicion of acute cholecystitis?
So it
Right,
is kind of biliary colic, sir. Postprandial pain.
biliary colic. So there
Yes,
were
sir.
multiple episodes of biliary colic.
So past one, actually a few episodes of biliary colic, sir.
Okay, Right. Please go ahead.
So,
Yes.
Vishal sir, may I ask? So, this is
Sure.
Anand sir. Gopi, with your history, in which group of patient will suspect such type of scenarios? Like this patient has a biliovascular injury, then which group of patient will think of that this patient may have a biliovascular injury?
Sir, patient who having a chronic cholecystitis and patient with portal bilioma, there might be a chance of biliovascular injury because of portal cavernous formation in the epidodymal ligament. And uh, acute cholecystitis, chronic cholecystitis, and portal hypertension with portal cavernous formation.
So, with the history of this patient, could you make out what the patient has had previously? Acute cholecystitis or chronic cholecystitis or biliary colic, as Dr. Vishal asked previously.
Sir, based on the history, it appears to be a biliary colic, sir. She
So-
doesn't have any fever, no history of jaundice, and no history of upper abdominal tenderness, sir. She's only experienced a pain, biliary colic, sir. Apart from nothing, sir.
Yes, go ahead.
General examination, patient is conscious, oriented to the time, place and person. She is moderately built and nourished, and hydration status is fair. There is no petechiae ecchymosis in the oral mucosa or lower limbs, and no pallor, not icteric, no pedal edema, no lymphadenopathy, and your BMI was 23.17 kilogram per meter square.
Dr. Gopi, just
This
want
is
to
the
stop.
finding preoperatively.
Sir,
What is the significance of this finding? No petechia ecchymosis in oral mucosa and lower lip.
sir, we are dealing with a patient with bile duct injury. So it associates with any liver decomposition. The patient might have any these findings of petechial ecchymosis, or if your patient having any bleeding diastasis, because it may signify, sir. And in the meantime, patient is having a severe sepsis, we can see the petechial ecchymosis because of deranged coagulation.
But in the context of your history, right?
Yes,
And
sir.
the salient examination point, like no pallor, no icterus, no pedal edema. So this finding categorically you have mentioned. So do you think that in the context of history, in the context of remaining negative findings, this becomes important? Because once you mention like this, lower limb, oral
No,
mucosa,
no, sir. Actually, patient doesn't have any signs of sepsis, so it doesn't signify anything, sir.
right? So you have to present findings in the context of your history, in the context of remaining examination findings, which are more universal and more important. So if the patient had pallor, patient was icteric, there was a history of spontaneous bleed in terms of like apex texas or mucosal bleeding, patient had septic features, patient was having features of portal hypertension, then such kind of findings becomes important. And in those scenario, if you did not mention this thing, then examiner will ask you. But in the absence of all those features, if you categorically mention no petechia, no ecchymosis, and oral mucosa and lower limb, then it becomes difficult for you to explain. This is
Okay, sir.
my just submission.
Yes, sir. Yes, sir. Yes, sir. Understood, sir. Thank you, sir.
And similarly, in the last, I think when you mentioned there was no history of tenderness, I think patient can tell you no history of pain, but tenderness is a sign.
Yes, sir.
Got the point? So you have to be
Yes, sir.
careful during the exam what you are saying.
Okay, sir.
Got the point? Right. Please
Yes,
go
sir.
ahead.
Vital signs. Here pulse rate is 80 per minute, saturation is 98% on room air, respiratory rate is 21 per minute, blood pressure is 120 by 80 millimeter mercury, temperature is normal. On examination of the abdomen, on inspection, abdomen is mildly distended, umbilicus is central and inverted. I can make out the port side suture, and there is a two drains. One is in the right upper quadrant, another is the left upper quadrant, which is draining a golden yellow bile with sediment. All the quadrants moves corresponding equally with respiration. No visible intestinal peristalsis. Hernial orifice are free and flanks appears free. There is no exploration, erythema or the drain site. On palpation, abdomen is soft, not tender.
Gopi,
Yes, sir.
visible venous prominence.
Sir, I just mentioned out she doesn't have uh, uh, portal hypertension, sir.
Why a patient of 5 days or staying very recent, a patient has undergone recently in very recent past police lab police scrutiny and has tried getting the how soon a mind injury produces cirrhosis and portal hypertension.
No, sir. I'm thinking in context of pre-existing cirrhosis with portal hypertension. She undergone a
That will not be, I see, in the previous history, it will be known. You see, when you are an MCH student, this is all expected from an MBBS student. When you are an MCH student, you are talking of that particular case. Don't mention all the things which are mentioned in SDAS or KDAS.
okay, sir.
See, you are presenting that particular case. Don't mention anything. Since I have not prominent,
Okay, sir.
Carry on.
Yes, sir. On palpation, abdomen is soft, non-tender. There is no gouging and rigidity, no organomegaly. There is no palpable lump. And percussion, liver dullness, we can make out on the fifth intercostal space. Liver span is about 12 centimeter. There is no fluid thrill. There is no shifting dullness. Auscultation, I can hear a normal bowel sounds. And digital rectal examination, tone is normal. Finger is trained with yellow stools. Other system examination, respiratory system.
Dr. Gopi, just go back. Dr. Gopi, just go back.
Yes.
Your DRE examination, right? So, what is the influence of this finding? Yellow stool.
Actually, she's having even if she's having a external biliary fistula, we can yellow stool means that she's having a normal intrabiliary circulation. That there is no interruption in the intrabiliary circulation. Yellow stools which indicates the bile pigments in the stool.
What is
I think,
the
Gopi, what does that mean? If you have done an ER and you find a yellow streak on your
Sir, she's doesn't have any clay color stool. There is no.
What does that mean? In this particular patient, what will be your inference?
She is having a bile duct injury, but biliary entry continuation she is maintaining, sir. I just emphasize on that.
It's an incomplete injury.
Yes, sir. Yes, sir. I just want to ensure that she is still having a biliary entry continuity. So she is having a normal enterobiliary circulation. Even she is having a controlled eye output biliary fistula.
go back one more slide. One more. So you have mentioned percutaneous drain tube in right and left upper quadrant, draining golden yellow bile with sediment, right? So I
Yes, sir.
think it would be better to mention that what is the quantity of bile in each drain. They are connected with some bag, right?
Yes, sir. Yes,
So
sir.
it becomes important to know the drain of output in each drain.
Yes, sir. And subhepatic drain is draining about 500 ml, sir. And peristaltic drain is draining about 150 ml per day, sir.
Daily. So it is
Yes, sir.
consistent, same amount, fixed amount, or is there any trend?
Sir, actually, it is draining almost 500 to 650 ml per day, sir, for past few days since our admission in our hospital.
So it is around, I think the total quantity would be
Total quantity would be 600 650 ml, sir, per day.
daily.
Approximately, sir. Yes, sir.
And they are PCD trained. It would be better to tell the size of the PCD at the same time if you can make out
Okay,
from
sir.
the PCD catheter.
Yes,
right?
sir. Yes, sir. Yes, sir. I didn't notice, sir. I will make a
No, you
note on
have to
that.
be categorically, right? So if a ADK drain is placed, right, you have mentioned what is the size, this 20, 24, 28 or something like that. If PCD is placed, it would be better, is 16, 18 or something like that, right? So at
Yes, sir.
MCH or DNB level, right, if you mention, you have to actually mention. So this indicates that how observant you have been during the examination of the patient.
Okay, sir.
Got the point?
Yes,
Please go
sir.
ahead.
Other system examination, respiratory system, normal vesicular blood zone I can make good. Bilateral larynx is equal. There is no added zone. Cardiovascular system, first and second out zone we can hear. There is no added zones. Central nervous system, your GCS is fine. She is conscious oriented to the time pleasant person. And uh, the diagnosis, sir. Should I go for a diagnosis, sir?
Yeah, please. So how will you
Uh,
approach this patient? So you have a tentative diagnosis of post cholecystectomy bile duct injury with high output controlled
external
external
lyric is
pulmonary fistula,
yes, sir.
right? So what would be your approach
Uh,
with this
uh,
tentative diagnosis or provisional diagnosis? How will you approach this patient?
uh, First, I will admit the patient, sir. I will go through the previous record and previous blood investigation.
Why will you admit this patient?
Sir,
Indications for admission. This patient has come to your OPD. So what you have presented with history and examination, what are the indications for admission?
the patient having a sepsis,
Is he
and if the
having a
patient
sepsis?
having a intraabdominal collection.
But we have mentioned it is a controlled high output fistula.
Yes, sir.
Where is the connection?
Okay,
Is he
sir.
having fever? Is he having tachycardia?
No, sir. She
So
doesn't
why
have
you are
any.
thinking she is in sepsis?
No, sir. She doesn't. She doesn't require admission, sir. First, I just want to go through the previous blood investigation.
Gopi,
Sir.
hello, Gopi.
Sir. Yes, sir.
So why sir is asking all these things, because you directly jumped on your diagnosis rather than it is probable diagnosis. Before jumping on the diagnosis, you should summarize your case. So in your case summary, it has to be mentioned that the patient presented with history of lap cholecystectomy 5 or 7 days back. So with these PCDs draining so much of amount, so my probable or in that summary you have to specifically mention that patient is not having any sign and symptoms of cholangitis, any sepsis. Then
Okay.
indirectly it is stating that the patient doesn't need any kind of admission. So patient wants a second opinion, a patient need your further management. So sir is asking your approach. So first, always make your habit while presenting your case, you have to summarize your case. In summary,
Okay,
you
sir.
have to mention all those presenting sign and symptoms for which the patient is there in your OPD, right?
Okay, sir. Summary, sir. 25 years old female, Miss Reshma, was diagnosed having a symptomatic gallstone disease, for which she underwent a lap cholecystectomy elsewhere on 4th January, and subsequently, intraoperatively, the event she underwent a blood transfusion. Postoperatively, on third postoperative, she was discharged with a drain, which was draining a serum hemorrhagic content, which was subsequently decreased in subsequent days. On sixth postoperative, the drain was taken out, and subsequently she developed a pain abdomen distension. On ninth post-op day, she was diagnosed having, she found out having an intraabdominal collection, for which she underwent a image-guided drainage along with
Gopi,
percutaneous drain
Gopi,
placement.
Gopi.
Yes, sir.
In summary, you don't need to describe the entire events which you have already described. Summary means summary itself. It's a summary. You have to be precise within either 4 to 5 lines at max.
Okay, sir.
Yeah.
Uh, uh, Post cholecystectomy, bile duct. Sir, okay, sir.
Okay, go ahead
Status.
with the approach. No, leave it.
Okay.
Go ahead with the approach. What sir is asking for you. Sir is asking, Vishal sir is asking you how you will approach this patient. Describe it.
Okay, sir. First, I will go through the previous records, sir, and for which she underwent a surgery. I just want to go through the records, and I would just want to check the preoperative liver function test, complete hemogram, and sonography abdomen. And I just want to go through the previous record. Presently, the patient doesn't have any signs of sepsis.
Why? Just hold on. Why you want previous pre-op LFT CBC of this
Sir,
patient? Does it make any difference?
it usually doesn't make any difference, sir. Might
And
sir,
before stating any statement, you have to justify yourself.
yes, sir. Preoperative LFT, I just want to know the liver function test is normal prior to the cholecystectomy or not. I just want to know the bilirubin and alkaline phosphatases in the preoperative level. And
Why?
Okay, suppose it is deranged. I would say bilirubin was 2 and SGOT was more or less normal, but alkaline phosphatase was twice the normal upper limit. Right. This is immediate. Patient has this LFT report 1 week prior to cholecystectomy. So now, how this will change your approach or your interpretation of the entire course of
sir,
events?
it won't change in the operation in the management of this patient, sir. Actually, it
Right.
indicates there might be a indication for they might have missed the CBD stone prior to the surgery. Under evaluation prior to the surgery. So I just want to know what could be the what could be the event that happened prior to the surgery.
Right. So basically, you will try to decipher the risk factors for the difficult cholecystectomy or
Yes, sir.
bile duct injury.
Yes, sir.
Right. You will not change the management except in one situation. Not based on the LFT, but based on a preoperative imaging. Especially in the North India, a situation which is relatively common than the South India, a disease process, which usually surgeon miss and then they encounter intraoperatively and then they go ahead without actually realizing what is the pathology.
Gopi sir is directly giving you a hint. North and South India, what is the difference between a gallbladder disease, which is more common in North India, not in South India?
Sir, actually, CA gallbladder is more common in
Definitely.
North.
It's a carcinoma of the gallbladder, which can be easily picked up pre-operatively, which a surgeon can miss or incidentally diagnose on intraop. So it directly change your management thing.
Yes, sir.
Okay.
And I just want to know the sonographic finding.
So do
It
you
is
have these reports in this patient? Do you
sir,
also
I have
give
a
RFT or ultrasound or
sir.
any other?
Actually, preoperative platinum session I don't have, sir. Not with the patient. I can go through the preoperative sonography, which is suggestive of multiple cholelithiasis
Right.
with no IHBRD dilatation, normal CBD. CBD is normal in caliber, sir, and
That's all.
pancreas is normal.
So what else do you want to see on ultrasound with a patient with gallstones?
Sir,
Is it enough to know that patient is having just gallstones or there are other findings which are important?
sir, I just want to know the stone is single or multiple. I just want to know the gallbladder wall thickening is there or not.
Right. So what was the
And
wall thickness?
sir, actually, they mentioned GB wall thickness is normal, sir.
Normal. And what was the time period? Means when was this ultrasound done before surgery? What was the interval between the ultrasound and the cholecystectomy? It was just
Sir,
immediate perioperative or
no, sir.
much before?
1 week prior to the surgery, she undergone sonography, sir.
So you have to categorically mention that there were multiple stones. Gallbladder wall thickness was normal. There was no evidence of cholecystitis. There was no evidence or suspicion of any malignancy. CVD was normal. Spleen. What about the spleen? You have mentioned that portal hypertension is a risk factor for the difficult
So
cholecystectomy or
spleen
bleeding.
in the preoperative sonography, they mentioned is normal, sir.
What about the portal vein? What about the ecotexture of the liver?
Yeah, liver echo structure is normal, sir. And
No.
they haven't come about the portal and these things, sir. And they haven't come about any
Right.
portal
So
bilium or
preoperative
portal
ultrasound
cavern.
were more or less normal except gallstone. Right. So
Yes, sir,
what
multiple.
other records would you like to review?
Uh, I would
Not
like,
preoperative, but any other record.
sir, I just want to compare the preoperative hemoglobin as well as the postoperative hemoglobin, sir. Actually, she underwent a transfusion of
Before
5
that,
units.
before that,
I just want to know
you want
the
to review the operative record?
Yes, sir. I just want to review the operative record, sir.
So are they available with you?
Sir, actually, the patient having a discharge summary only, they mentioned lab cholecystectomy without CBD exploration in the operative
CBD
notes. There's no detailed notes, sir. Detailed notes is not available, sir.
So they have just performed the colostectomy plus CBD exploration.
No, sir. Lab cholecystectomy without CBD exploration. They mentioned this
Without
in
CBD
the.
exploration.
Yes,
So
sir.
they must have some kind of code, na hospital code. Ayushman code is like this only. Lab colostectomy without CBD exploration with CBD exploration. So they have used the code. Otherwise, you don't mention like this lab colostectomy without CBD exploration.
Yes, sir.
Okay.
Yes, and in the meantime, I just want to know about what all the events happened during intraoperatively. I just want to discuss with the uh, primary surgeon who operated on her, sir. And I just want to know what could have happened during intraoperatively. And in the meantime, I also want to check the coagulation profile.
Like you have reviewed the preoperative records, you have reviewed the intraoperative records. You could not find much of the details, right? And now,
Yes, sir.
how will you go ahead?
Presently, patient doesn't have any signs of sepsis. Patient accepting a oral diet, and there is a controlled aortoexternal biliary fistula. I want to know the biliary anatomy by means of imaging, sir. In this patient, I just want to know the biliary entry continuous main. In this patient, I just want to do the MRCP to delineate the anatomy of the biliary tree, sir. In this patient, I will do the basic blood investigation, complete blood
Last,
count, and LFT along with coagulation profile, followed by MRCP. Sir.
hello,
Yes, sir.
please go ahead.
Sir, I will do the basic blood investigation, which includes CBC to look for a hemoglobin and total count. In the meantime, I would like to do the liver function test,
Mhm.
and I would like to do the PTINR of the coagulation profile of this patient, sir, PTINR.
What about
And
electrolyte?
electrolyte also I would like to do, sir, because she's having high output the extent biliary fistula.
What is the most important investigation that you would like to do at this stage?
Sir, electrolyte and LFT is the most important blood parameters we need to look into, sir. In the meantime, we need to check about the total count.
Imaging wise,
Imaging wise, she underwent sonography on 17th. So,
So what is the
at,
purpose of getting sonography? And if
sir,
I give you option MRI, MRCP versus CT
uh,
scan.
sir, actually, last sonography is available, which is suggestive intraabdominal collection. They drain the collection, and presently is draining outside. So at present, there is no need for sonographic initiation at present, sir. And I would like to.
Indirectly, I will ask you. Indirectly, I will ask you. Patient underwent colostectomy on 4th. Today is 21st. So after around 17 days, what is the aim of your management in this
Uh,
patient where you are suspecting or there is a, I think, bile duct injury after colostectomy and patient is having high output external controlled release data. So what is the overall aim of management at this stage?
Sir, we need to delineate the anatomy where the injury has happened. So for that, I would like to do the MRCP, uh, MRCP to this patient, sir.
Mhm. And MRCP shows it is a type 3 injury or there is a complete transaction. So then,
Uh, the patient having a complete transaction, they presented yearly. We
so
can go for a yearly.
will it change your management at this stage?
No, sir. No,
What
sir.
else did you suspect? What else did you suspect in the overall sequence of events, which is more sinister than the biliary injury?
It might displacement of clip we applied in the cystic.
No, you suspected vascular injury as well, no?
Yes,
Isn't
sir.
it?
Yes, sir.
There is a very, very strong suspicion of associated vascular injury,
Yes, sir.
right?
And I would like
So
to do
at this
the
stage, uh,
angiography also, sir, along with if the creatinine is normal, I would like to do the CT with CT angiography to look for the vascular anatomy.
right? I think, in my view, it is better to get CT scan, triple phase CT scan at this stage rather than getting just MRI. Or if you want to get the MRI, then you get the contrast MR plus
Yes,
MRI.
sir. MR plus MR angiography. MR.
See, biliary anatomy, you will just have assessment of kind of injury. But at this stage, you are not going to repair it. It is almost 3 weeks,
Yes, sir.
right? What is
Yes,
more
sir.
important is to know the underlying vascular injury status, if it is there or not. If it is there, whether it is amenable for any kind of intervention at this stage,
Yes, sir.
right? And it will
Yes, sir.
also affect your subsequent planning in terms of timing of repair or maybe outcome or your prognosticating to the patient.
Yes, sir.
This is in terms of imaging, but in terms of management,
In terms of
how will you
management,
manage the biliary fistula at this stage? Can you do something to make it low output? It is a high output control fistula.
sir, I don't know the answers, sir.
No, means it is a controlled external biliary fistula, high output, around 600, 650 ml, right?
Yes, sir.
So what is the, otherwise, what is the daily bile production
So it's
per day?
about 1500 to 2000 ml per day, sir.
Sure.
Yes, sir.
I think it is up to 1 liter per day, not 1.5 to 2 liters. You can check it again, right?
Okay, sir.
So it is a controlled high output fistula. So you want to assess the anatomy, you want to assess the associated vascular injury, and then you have to rule out any collection because this PCD was done after previous ultrasound, right?
Yes, sir.
So you
Yes,
want to
sir.
reassess it. Clinically, there is no sepsis. There is a controlled high output fistula, so you have to take care of the electrolytes, you have to take care of the nutritional status also, because at this stage you are not going to repair it,
Yes, sir.
right? And meanwhile, once you have assessed the anatomy, what is the kind of injury? Acha, what is the current LFT? I just missed. What is the
Current
current
LFT,
LFT?
it's available, sir.
What are the
And
current labs?
current
PVC,
current
LFT,
yes
CRP?
sir, yes sir. Hemoglobin is 12 grams, sir. Total count is 22,500. Differential count is neutrophil is 84%. Platelet is 5.4 lakhs.
So this
And
CVC, go back. This CVC is after PCD or before PCD?
after PCD, sir, after
So
admission,
what
sir.
is the inference? What is the inference with this CVC?
Sir, patient having a total count is elevated, predominantly neutrophil. So there is a uh, there is evidence of infection is there, sir. Even she doesn't have any signs of sepsis.
Right. So what are the causes of such kind of picture even after PCD? Patient has bile duct injury. Patient had multiple PCDs. Still, clinically there is no fever, but TLC is grossly deranged. So this is a consistent finding or this is a one-time finding?
Uh, Sir, actually,
Okay. So
it
you
is
want to repeat it, confirm it because
yes, sir.
clinically patient is not having sepsis.
We need to repeat the count and we need to know whether it is
It
inflamed
is
or
high.
then we can think in terms of might having a uh, source of infection somewhere, and we need
Where,
to
where will you
we need
suspect it?
sir.
Where will you suspect it? Source of infection in this scenario.
Uh, Sir, it might having a small undrained collection intraperitoneal cavity. It
Right.
might be a cannula-related infection like thrombophlebitis,
It may be some cholangitis. What is the LFT pattern? So you say that
and
I will correlate with the LFT also. You will get the CRP, you will get the LFT.
yes, sir.
What is the LFT pattern?
Yes, sir.
What is the LFT?
LFT total is 0.9, sir. Direct is 0.5, indirect is 0.4. SGOTPT is 2613 within the normal limit. Alkaline phosphate is 164. The cutoff value is 37 to 98. Gamma glutamate transfer is 113. The cutoff value is 78. That value. Total
Does it
protein
suggest
6.8 gram.
does it suggest cholangitis?
Uh, Actually, she doesn't have any evidence of cholangitis, sir, as per the liver function, liver profile.
Right. So the TLC is raised. Patient might be having subclinical sepsis, but the source of sepsis is not appears to be in the liver. It is not from the
Yes,
bleeding
sir.
system. It must be something from outside. So it may be some collection.
Yes, sir. Some
So
untrained
if you
collection
get the
or
CT scan, you can know whether it is a truly a controlled external various fistula or it is a indirect uncontrolled kind of fistula. Some collection is still there.
yes, sir.
And nutritionally, albumin is 3.1. So more or less she is maintaining.
She is maintaining the nutrition, sir. Yes, sir.
Anything else that you would like to get in the context of raised TLC?
Mm. Uh, Sir, she doesn't have any signs, so there is no need for uh, blood or urine culture, sir. And
Any
we
other
need to
culture which
check
is more
the
important?
inflammatory markers, CRP protein, and ES, sir.
Any other culture which is more important than blood or urine?
Sir, actually, they did a culture from the PD, sir, which is suggestive of E. coli. And patients getting antibiotic according to that culture and sensitivity, sir.
So you have to
Presently.
mention, you have to mention that.
Yes, sir. About to mention that the PCD culture is E. coli. She is getting antibiotic according to the culture and sensitivity. And electrolyte is normal, sir. We did a basic blood investigation only.
Right, right.
And
So what is the metabolic abnormality in a patient with chronic high output external biliary fistula?
uh, Sir, chloride, potassium and chloride will be low. The patient having high output, extremely this class. Sir.
Metabolic acidosis, alkalosis. Shall we go ahead? So what are you planning?
Sir, I just want.
When will you? Patient is asking you, sir, when this fistula will be closed, or when will you operate?
Sir, I need to wait minimum period of 6 weeks, sir. Prior to any surgical intervention from the incident of bile duct injury, I will wait for a minimum 6 weeks. And in the meantime, I just want to know the patient having a sepsis or she doesn't have any sepsis. First, I will control the sepsis and I will write the nutrition and alliterate abnormality. In the meantime, I just want to delineate the anatomy where the injury has been occurred. And based on this, I will proceed. The patient warrants a surgery, then I will proceed after the 6 weeks, sir.
You are answering like this things like theory exam. This is a practical exam. What will you do in this particular case? Patient has come to you. You are the treating clinician. Now you tell what will you do?
Sir, I just want to delay the anatomy and I just want to rule out any vascular injuries. So I will do the full CT with angiogram.
Now, 3 weeks later, if he obviously if she had a vascular injury, what will you do? 3 weeks later.
Sir, if she's, I just want to know the patient having any pseudoaneurysm along the tertiary of hepatic. Pseudoaneurysm is there or not, sir? If pseudoaneurysm is there, I want to coil the pseudoaneurysm, sir.
Yeah.
There is a chance of rebleeding.
Yes. You see this. Remember, most of these students, and this is for all the residents who are in the attendance. You are being examined, or it's a clinical examination. Theory you have already cleared. So you are talking of this particular patient. So you tell how will you manage this particular patient? How will you reach diagnosis? Then how will you proceed thereafter? Patient has, you have already diagnosed the patient has because it necessitated in a level 4 minutes of blood transfusion, consequently, this requires 5 minutes of blood transfusion in a unit of so you see that now since I consider there is a high amount of injury associated, I do not have
Sir, based on that, I will proceed further, sir.
Yeah, proceed.
Yes, sir. I will do the CT with angiography, and I will first delineate the anatomy and to rule out.
Vishal sir, can I ask something? Sorry, I'm Dr. Sahil.
Yes, sir. Good morning, sir.
Good morning, Gopi. You are again and again saying it's CT angio with angiography. As Vishal sir corrected you before, it should be CT triple phase. It can be portal vein injury also, na?
Yes, sir. Yes, sir.
How can we assure it's a arterial injury? It can be a portal vein injury. She required 3 units of blood transfusion in 90 minutes.
Yes, sir.
So, as Vishal sir suggested, it should be a CT triple phase rather than CT angiography alone.
Okay, sir.
And you have additional advantage now because you are suspecting underlying sepsis, some undrained collection. So you have to have a screening of the entire abdomen for collection and for any kind of vascular injury. And not necessarily it is a hepatic arterial injury or portal venous injury, it is a femoral branches of the middle hepatic vein. You can have bleeding from the GB bed when you go deep
Liver
into the liver
parenchyma. Yes, sir.
parenchyma, and the bleeding is from the femoral branches of the middle hepatic vein. So, hepatic artery portal veins might be normal. Got the point? So you can have the
Yes.
screening at this stage for the all kind of problems we might be having.
Okay, sir. Okay, sir.
तो कैसे अभी अप्रोच करोगे इसके आगे? LFT हो गया, CBC हो गया, CBC में there is a suspicion of sepsis, LFT is more or less normal, nutritional status is more or less normal, right? Clinically she is not having fever, she is on antibiotic based on culture. So what is your next planning? Because patient will ask you ना, सर अब क्या
Yes, sir.
करना है आगे?
Yes, yes, sir. Based on the triple plus CT finding only, I will proceed further, sir. If triple plus CT shows there is no any problem with
It has
collection.
been done. Do you have
No,
any
sir.
process
We
for
haven't done,
imaging?
sir. No, sir. We haven't done imaging first, sir.
Okay. So we don't have the any MR or CT scan, right?
Yes, sir.
ठीक है. And patient is asking you to operate at this stage, or your referring surgeon, they ask it is a control external biliary fistula. Just operate it. Right? Will you
Sir,
operate?
no, sir. No, sir. I wait for a 6 weeks, sir, to mature the track, and if there is any stricture, we will get a. I will wait for a 6 weeks, sir.
And what about suppose there is a right hepatic arterial injury on the CT scan? There is suspicion of hepatic arterial injury. Then, so is there any
Sir,
fixed time frame that you will wait for 6 weeks? Today, 6 week is completing. Will you operate on the 43rd day?
sir,
And
we just
from which time point you start 6 weeks? It is from the cholecystectomy or it is from something else?
it is from the control of sepsis to the 6 weeks,
Right,
sir.
right. So not necessarily it is just 6 weeks. Huh? And suppose there is
Yes,
an
sir.
associated vascular injury, then hepatic arterial injury.
Vascular injury, if it is available for reconstruction within 48 hours, we need to go as immediately, sir.
This patient and this patient now it is already 3 weeks.
Actually, first with hepatic arterial injury, we need to wait and watch if there is any signs of liver failure or
The
ischemic.
time period has already passed out huh, for liver failure. It is almost 3 weeks. अगर होना होता तो पहले ही हो चुका होता. अभी तो नहीं होगा ना.
Yes, sir. Yes, sir. And
तो आज की बात कर रहे हैं कि today if you get the CT scan there is no major collection, there is a mild IGRT, CVD continuity they could not be traced, and there is a suspicion of right hepatic arterial injury. There is a discontinuity, there is no pseudoaneurysm. Then in this finding, will your timing will change or still you want to operate after 6 weeks?
Sir, actually, will give us some time to develop a. Sir, I don't know the answer, sir.
So what is the effect of associated arterial injury on the bile duct injury in terms of its grading or severity or type? Is it a fixed injury or does the injury evolve over a period of time? So today, if you see it as a type 1 injury or type 2 injury, it
It
will
is a
stay
fixed.
like this after 6 or 8 weeks, or it will evolve or matures
No,
into
sir.
some other kind of injury.
No, sir. It will be the same, sir.
Sure. What is the blood supply, arterial supply of extrahepatic biliary system?
Extrahepatic biliary system, which get from the cortical cells, sir. Usually it runs around the 3 and 9 o'clock portion. Usually from the gastroduodenal superior pancreatic duodenal artery will give the branches along the 3 and 9 o'clock portion. Near the island, it is from the hepatic artery, sir.
Right. So what is the classical bile duct injury? What could be the mechanism of injury in this particular patient? What is the name of this classical bile duct injury mechanism and how it happens? In classical bile duct injury during laparoscopic hysterectomy, what happens?
Sir, actually, there is a misidentification of structure, sir, and
Which
there is
structure?
a
Which structure?
misidentification. Sir,
Which structure?
actually, instead of cystic duct, we may identify the right septal duct or common hepatic duct. We'll think in terms of
Common
cystic
hepatic
duct,
duct or Mhm.
and there is a upper anatomy. There is an inflammation in the porta, and
No,
there may
these
be
are
a
the
frozen
causes.
cal.
These are the causes. What is the mechanism?
Sir, I don't know, sir.
You think CBD is the cystic duct, you clip and divide it, you dissect medial to cystic duct CBD, then you mobilize it, then you again clip and divide the common hepatic
Hepatic.
duct, right? And at the same
Yes,
time,
sir.
you can also do the same injury with the right hepatic artery, thinking that it is the cystic artery. Got the point? So this is the
Yes, sir.
classical Davidoff bile duct injury. When you resect the segment of the common bile duct and common hepatic duct along with the cystic duct with its junction, and you also resect the segment of the right hepatic artery. So when there is a combined injury, there is a ischemic necrosis of the proximal segment as well.
Proximal segment and
Okay,
proximal bile duct. Yes, sir.
and
Yes,
if you don't do the classical injury, there may be some ischemic injury related to the use of the cautery.
Country.
Got the point? So these injuries they
Yes, sir.
evolve over a period of time. If you transact, it is a one-time injury. It may not recede, it may not proceed. But if it is an injury with the cautery or it is a ischemic injury, they evolve over a period of time. So suppose at 3 weeks or 2 weeks, it is a type 2 injury. Maybe after 6 or 8 weeks, it is a type 3 or maybe a type 4. So you
Yes, sir.
wait
Yes,
for
sir. Yes,
some
sir. I got
time.
it, sir.
Got it?
Yes, sir. Yes, sir.
Good.
Yes, sir. I got it, sir.
So just last question from my side. What are the prerequisites for a successful repair?
Prerequisite for a repair.
Successful
First one
repair.
is first thing is there is there is a no evidence of no evidence control of sepsis, and we need to build the nutrition of the patient. And third one is we need to delineate the clear-cut anatomy. Then we need to do the tension-free anastomosis. Tension-free anastomosis. Usually, in case of bile duct injury, if having complete transaction. And
mucosa to mucosa, healthy and
tension-free ductomucosa.
the tension-free is the universal
With vellomuscular anastomosis.
for any anastomosis. And one last point. All systems should be drained.
Yes, sir. All sessions should be drained. Yes, sir.
Toby sir, would you like to ask any other question?
No, I think thank you very much.
Thank you, Vishal sir, for moderating the today's session.
Thank you.
Thank you. Yes, we can wind up today's session. Thank you, sir.
Thank you.
Thank you, sir.